Good morning, friends. Tanvir, Sean, can you just confirm you can hear me and see my slide?
Yep, everything's fine.
Yeah.
Okay, excellent. Okay, thank you. So, friends, let's begin our next session on the venous anatomy of the brain. So last week we had a tour through the arterial anatomy, and arteries really have been kind of glorified over the years. Uh, Perhaps it's because the consequences of arterial disease can be quite catastrophic, aneurysmal disease or strokes. Uh, and also they're eminently treatable as well from the neurosurgical perspective. And somewhere the understanding of venous anatomy and the venous pathophysiology behind the disease has lagged a little bit behind, but it is catching up. And certainly in the last 25, 30 years, the understanding of venous hemodynamics, the anatomy of the veins has substantially improved, especially with additional imaging techniques that are now available to us. So over the next hour and a bit, we will look at the anatomy of the venous system, and as before, we will look at a bit of embryology, and then mainly anatomical examples with some pathology to highlight the anatomy behind it. So let's begin, friends. So the looking at the embryology of the veins, seems a little bit more complex than the standard arterial anatomy. Arterial anatomy is sort of very much segmental, as we saw behaving how the sclerotomes behave within the cranial counterpart. Uh, Venous anatomy, like and the embryology, does not behave in a similar segmental pattern. And hence it appears on the surface a little bit more complex, and also is responsible for the extreme variations in the anatomy that we see in clinical practice. So I'll try and simplify it without going into too much detail, but it is still pertinent to understand this embryology so that it helps us understand the variations, but more important, it will help us plan treatment and understand when the treatment doesn't work and why it doesn't work. And again, I will share that with some of the examples later on. So, so here we have a very early embryo, 5 weeks, 6 weeks earlier on. And what we are seeing here in this first slide over here is a very primitive sinus, which is called as a primitive head sinus, which has developed. And on the dorsal aspect, you get a mesenchymal plexuses, which develop the anterior, the middle, and the posterior dorsal plexus. So again, it's important to realize that the invagination of the mesenchyme into the growing neural tube, which we saw in the arterial system, is very, very similar on the venous side as well. The invagination does occur from the dorsal aspect and extends centripetally towards the ependymal margin, and then longitudinally and transversely the vasculogenesis of the rest of the structures takes place. So we have got the anterior, the middle, and the posterior dorsal venous plexa, if you like, and they kind of drain into the primitive head sinus, and this primitive head sinus eventually will drain via the cardinal veins, which is a precursor for the internal jugular vein towards the heart. What happens subsequently, the anterior dural plexus, which is developing around the developing telencephalon, is going to change its orientation, and it's going to go get more and more directed posteriorly, and that is reflected by the growing of the telencephalon. And the most important structure in that aspect is this primitive marginal sinus, which drains via the telencephalic vein. And this primitive marginal sinus is kind of the precursor of our spinoparietal sinus and the superficial middle cerebral vein, and we'll look at that anatomy a bit later on. So that's one of the concepts to understand. The second concept to understand is that these plexi are not necessarily the prosencephalon, mesencephalon, and the rhombencephalon, but they are in continuity over the surface of the cerebrum. So the middle and the posterior, plexi will eventually fuse together, and they later on will form the sigmoid and the transverse sinus in that region. And the third important concept is that the developing otic region and the effect it has on the development of this primitive head sinus. So just to go on the next slide, imagine this again, just to remember, we've got a three plexuses over here, the primitive head sinus into which this drain, we have got the developing otic sinus over here, and then the primitive marginal sinus, which is going to form later on the superficial middle cerebral vein. So if you were to just move on, you can see the developing telencephalon, the primitive marginal sinus is eventually going to drain at the posterior aspect into the developing superior sagittal sinus, which is formed by the primitive marginal sinus, but also by the fusion of the dorsal venous plexuses. The developing otic sinus is going to then make the primitive head sinus a little bit defunct. And what it does is it stimulates some growth of veins around the orbit, around the pharyngeal plexus. And this is the precursor for the cavernous sinus. So the cavernous sinus region drains the orbit, the pharyngeal areas, but is also in continuity with the lower end of this primitive head sinus, which now is actually the inferior petrosal sinus. And again, we'll look at this anatomy a bit in detail later on. So here we have the superficial middle cerebral veins, which are developing, which are going to drain into this precursor of the tentorial sinus, which later on will obliterate, and that drains into the developing sigmoid and the transverse sinuses, which are formed by the fusion of the middle and the posterior plexi, which we saw earlier on. So this is kind of an overview, if you like, of how the venous sinuses are developing. So remember the dorsal venous plexi, remember the development of the telencephalon and its effect that has on the development of the superficial middle cerebral vein, the development of the otic sinus and its effect on the primitive head sinus, which eventually will form the cavernous sinus and its tributaries. Okay, so that was a brief overview, if you like. So now let's look at the anatomy of the cerebral veins. Uh, and for simplicity, I have kind of divided them into these various groups. It makes easy for us to understand when we're looking at anatomy. But of course, the interplay of blood flow through these structures is very, very interesting. If you look at an angiogram, it changes from day to day, from morning to evening. It will depend upon whether you're breathing heavily or not, if there is a Valsalva maneuver, if there are any pathologies along the way. So the venous circulation is extremely interesting in terms of how it flows. Even if you're erect or supine, it changes the direction of flow. So we have got the superficial veins, we have got the deep veins we'll look into, the venous sinuses, we will look at the infratentorial structures, and finally we'll end with having a look at how the veins actually, after all of these collections, how does it get outside the head. So let's start with the superficial veins. Okay, so as the name suggests, these are superficial. So they drain the superficial aspects, the outer aspects of the brain. And these are numerous ones. If anyone of you has seen angiograms, will realize the numerous cortical veins which drain towards the superior sagittal sinus, not necessarily towards the superior sagittal sinus, but also towards the transverse sinuses. So you have got all of these unnamed ones, which are there, numerous ones. But one of them, typically around the central sulcus region, is quite big, and we give them a special name called the vein of Trollard, which is here the big one that you can see. Similarly, along the inferior aspect is another big vein, which is called as a vein of Labe, which kind of drains the posterior temporal lobe, which is here shown on this sagittal MIP CT venogram reconstruction. So the three groups of veins that we need to think about when we're looking at the talking about the superficial vein, of course, you have got the innumerable cortical veins, the vein of Trollard, the largest one, typically around the central or the precentral region, the vein of Labe, which drains a fair proportion of the posterior temporal lobe, and then the superficial middle cerebral veins, which drain the inferior and anterior aspect of the cerebral convexity. So kind of the inferior frontal lobe, the temporal lobe in its anterior aspect, also uh, a fair amount of the inferior parietal lobule will drain anteriorly via the superficial middle cerebral veins. Another point to realize is these veins do not join in directly. What they do is they join in sort of in a fashion that is retrograde. So the blood is flowing from anterior to posterior. The blood is flowing from anterior to posterior. But look how the veins are. The veins are actually retrograde in their orientation towards the sinus. And that also reflects how the enlargement of the growing cerebrum has affected the veins, which normally would have been straight, but because of that overgrowth has resulted in this typical appearance of these cortical veins. Again, to share you the examples on an angiogram. So this is a lateral internal carotid angiogram. The venous phase, you can see the superior sagittal sinus along its whole length. This is where the torcula would be. You can see the veins draining down into the sigmoid sinus and then the jugular vein. And all of these numerous cortical veins which are draining against the flow of the vein within the sinus. This big one, the vein of Trollard. This one, which is the anastomotic vein of Labbé, and these groups of veins, sometimes you can see a single vein, but quite often there can be 2, 3, or 4 venous groups which converge anteriorly towards the wing of sphenoid and then drain inferiorly towards the cavernous sinus. And these are the superficial middle cerebral veins. Sometimes they can form a sinus called as a sphenoparietal sinus near the wing of sphenoid. And look at the interplay between these 3 veins. Here the anastomose around the inferior parietal lobule, and hence there can be a bit of codominance or interplay in the size of these. If one of them is rudimentary, the other venous structure will take over the functioning, the venous drainage of that pertinent area. And this is a CT venogram again to show you again the same what we see on a catheter angiogram. And this is what we saw earlier on, the vein of Trollard, the vein of Labbé, and the multiple middle cerebral veins, which we don't see over here, but they will be oriented in that direction. These cortical veins, of course, you can see them on angiogram. You can see them on CT venogram. Just to show you some pathology that we can see, this is a patient with a hemiplegic migraine, and that can cause derangement in the cerebral blood flow. And here what you can see is the engorgement of these cortical veins extensively on the left side because of transient hypoperfusion, which can then exaggerate the deoxygenated blood within on this SWI sequence, accentuates the paramagnetic properties, and hence you can see the blooming effect of this on this SWI sequence. And on this post contrast, perhaps with the eye of faith, you can see some bit more enhancement than what you would expect. And this is a patient who had a ABM which had a radiotherapy for it. And this is about 2 years after the radiotherapy, patient developed seizures. And just to show you that here we have a ghost of the vein, which is thrombosed on the coronal CT venogram. And here you can see the thrombosed vein as well. So cortical veins, a bit difficult to see the pathology on a CT venogram, but here you can see the thrombosed vein, which was responsible for delayed onset seizures in this individual. So this is about the cortical veins. We have looked at the vein of Labbé. This is a patient who developed spontaneous hematoma within the posterior aspect of the temporal lobe, and you can see on the MR scan. And this is a phase contrast venogram where you can see the hematoma, of course, but what you can see also is that thrombus in that vein of Labbé, which is going to be around this area over here, exactly where it drains into the distal aspect of the transverse sinus, the lateral sinus, as it joins towards the sigmoid sinus. So this is thrombosis within the vein of Labbé, resulting in a venous hemorrhagic infarction in this individual. Uh, Again, imaging, we can look at the veins, and it's essential, especially when you have got your neurosurgical colleagues who want to plan surgery around these tumors, where it's so crucial to identify these veins. So this is a patient who's got a meningioma. This is a different patient down here. The meningioma is highlighted in blue, but just to show to the surgeon how the veins are splayed around, especially when we are dealing with venous anatomy around the central sulcus. Extremely important to identify these veins with respect to the surgery, to the tumor, so that you can enable and help the surgeon, your surgical colleague, to preserve these veins in order to avoid surgical complications. And here is another patient here to show you how the tumor, the meningioma, has actually invaded into the superior sagittal sinus. Again, very, very important to identify this fact prior to surgery, so that the trauma to the superior sagittal sinus can be avoided, or indeed, if radical cure is essential, then the venous anatomy can be mapped in relation to the tumor. Right. So that was about the cortical veins. We have looked at the vein of Labate, Trollard. Let's look in detail at the superficial and middle cerebral vein. So this is the vein which we looked at briefly before. We said it drains anteriorly along the inferior aspect of the frontal lobe, superior aspect of the temporal lobe, and also the inferior parietal lobule. And these can be single vein or sometimes about 2 or 3 or 4 of them sometimes. And these as they converge inferiorly towards the skull base, they hug the posterior margin of the sphenoid ridge, as you can see here, and they can form a sinus. Sometimes these are called as sphenoparietal sinuses, but in effect, they're individual veins which are draining this part of the brain, and they converge towards the cavernous sinus, and most of these veins will enter into the cavernous sinus. And this is what we are seeing here. This is the trollard vein. We can barely see the vein of Labe, which is this structure here, and these are the great superficial middle cerebral veins as they converge, and you can see the ridge of the sphenoid highlighted by this sphenoparietal sinus or the superficial middle cerebral veins. The venous drainage finally usually is into the cavernous sinus, but then they can drain variably. Sometimes they can go outside the cavernous sinus and drain via the foramen ovale. Sometimes they can go over the petrous ridge and can drain into the petrosal sinuses, or sometimes occasionally into the basal vein. And this is what we have shown on a CT venogram over here. This is again a zoomed in picture of the anterior skull base. Just to orient you, this is going to be the sphenoid ridge. The sella is here, the petrous bone is here. You can see the basilar artery. Some of the circle of Willis is actually superimposed, and what is shown here is the middle cerebral artery, but just in front of the middle cerebral artery is the SMCV, the superficial middle cerebral vein, which drains into the cavernous sinus. In this patient over here, this is again that same superficial middle cerebral vein we have been studying, but look, instead of draining towards the cavernous sinus, it has in fact has taken an unusual course along that primitive tentorial sinus, along the floor of the of the middle cranial fossa, and then has drained posteriorly towards the sigmoid lateral sinus junction. And this is another example, again a zoomed in appearance. Here you have got the superficial middle cerebral vein, which is going to go along the wing of sphenoid. The wing of sphenoid is somewhere here. You've got the anterior clonid processes on both sides, and normally it should drain into the cavernous sinus, but what it has done is, instead of draining into the cavernous sinus, we will look at this vein a bit later on. This is the basal vein, and eventually it has drained into the basal vein. And it's important to identify this venous anatomy, especially if you're planning treatment around these venous structures, be it a fistula or a tumor or an AVM. So that's a bit about the superficial veins. Let's look at the deep venous system now. So the deep venous system, as the name suggests, it's deep. So it's going to drain the deeper structures. It's going to drain the thalami. It's going to drain the basal ganglia structures, but also some of the hypothalamus, subthalamus, the optic chiasm, and the choroid plexus. Uh, and these are kind of arranged in two layers, if you like. So you have got the internal cerebral veins, which run along the roof of the third ventricle, round about here. And then we have got the basal vein of Rosenthal, the complex of it, which is around the base of the brain, along the floor of the third ventricle, and it's oriented in that direction. So here it is, the internal cerebral vein, which is going to be along the roof of the third ventricle, just underneath the corpus callosum over there. So these are the internal cerebral veins. And then the basal vein, which is along the floor of the brain, which is along the floor of the third ventricle, which is here, and these join towards the vein of Galen, which is round about here. So this is the anatomy here on the CT. And this is again that same sequence which I showed earlier on for the patient with the hemiplegic migraine. This is a SWI sequence. It's a beautiful sequence to highlight the veins, and you can see how the venous structures are quite eloquently demonstrated here. And these are the internal cerebral veins, and we look at the anatomy of these internal cerebral veins in detail now. So what we are going to look at the deep venous system is the internal cerebral vein, the galenic system. We're going to look next at the basal vein of Rosenthal, and we are also going to look at some of the transcerebral vein and their importance. So the internal cerebral veins, as I said, these are paired venous structures. You can see there are two of them on either side, situated in the roof of the third ventricle, which is around about here, and they drain the caudate nucleus. They will drain the septum cavum septum. They will drain the thalamus, but they will also drain some of the choroid plexuses, and they will also drain some of the ventricular veins too. So this is the anatomy here, just to show you these paired venous structures as they come along, and just underneath the splenium of the corpus callosum, they will join together to form the vein of Galen. And this is just a 3D reconstruction of the same appearance over here. The two internal cerebral veins which are formed, and then the atrial veins which join in together. These are the terminal bits of the basal vein. The basal vein are not in the midline, they are on either side, and we'll look at that anatomy a bit later on. And this is just to show the confluence of the internal cerebral vein with the vein of Galen, then the straight sinus, and these are the basal vein of Rosenthal, which are there on either side. So this is kind of the anatomy of the internal cerebral veins. Let's just look at some of the tributaries of them. So here we are, the internal cerebral veins. You've got a caudate vein, named so because it drains the caudate. Then we have got the septal vein, it's drained the septum, but also a bit of this corpus callosum anterior body and genu. And these join together along with the thalamostriate vein to form the internal cerebral vein. And the previous prior to CT scans, these was called as the venous angle, very, very crucial when you're analyzing it on a venous, on an angiogram. But of course, now we don't need to analyze angiograms to detect tumors. We can do that with MR scans. Uh, uh, Moving on from these deep venous structures, from the internal cerebral veins and its tributaries, you have to understand, again, like the cortical veins, they are in a hemodynamic balance with the rest of the cerebral venous system. And this is done by these medullary veins. The medullary veins are basically veins which cross through. They're the transmantle veins which go through and through. This is again the SWI sequence, which will communicate with the cortical veins on the surface with the deep veins. And you can see the ventricular veins are quite prominent in this patient, which would mean that it is very likely that the cortical veins are going to be small in size as compared to the deep veins. And this is an interplay, just to show you the interplay between the deep veins, quite prominent. The cortical veins are small in size, and that is purely because the venous drainage in this individual is more deeper, and hence the ependymal veins are very prominent as they're draining via these medullary veins. So the blood flow in this patient, you can see the veins are smaller here and get bigger here, and that is because they're collecting blood as they drain towards the deep venous system. So these are the medullary veins. Uh, so the blood that is collected via these internal cerebral veins, the basal vein of Rosenthal, is going to get collected into the vein of Galen. So the vein of Galen is a straight structure. It curves behind the splenium of the corpus callosum. It is unpaired, of course, because it is single. It drains not only the internal cerebral vein and the basal vein, but also it will drain the inferior sagittal sinus, and it drains some of the occipital veins as well as the superior cerebellar vein, which you can see just about here. So that's the location of the vein of Galen, which will then continue as a straight sinus in the midline. Which is what we are seeing here. So this is a straight sinus, which is indeed parallel to the superior sagittal sinus. Sometimes you do get the inferior sagittal sinus, which is a small structure that you can see the inferior sagittal sinus. And again, the inferior sagittal sinus will be in balance with the superior sagittal sinus, depending on how the veins are draining. Most of the times, well over 95% of the times, the veins in the superior aspect will be draining towards the superior sagittal sinus, but occasionally you can get a dominance of the inferior sagittal sinus, which drains into the straight sinus. Uh, Something to remember are these Pachyunion granulations or arachnoid granulations. A bit more of this later on, but this is a very typical site where you can see this filling defect around it, a classical site where at the junction of the vein of Galen with the straight sinus, not to be confused with a clot. Some practical examples, of course, this is a plain CT scan, and you can obviously see the hypodensity within the medial thalami, the basal ganglia. Immediately we know it's not going to be arterial because it is at least in two different vascular territories. We know basal ganglia predominantly are anterior circulation, while the thalami are posterior circulation, arterial. So this is certainly more than one arterial territory, and you can see this hyperdensity in the medial aspect of the thalami in the roof of the third ventricle, which of course is thrombus sitting within the internal cerebral veins. And on the CT venogram, you can see the absence on this 3D reconstruction, and on this MIP image, you can see the normal appearance being absent of the parallel channels, and you can see the thrombus within the vein of Galen, but also within the straight sinus, which is expanded. And the enhancement that we are seeing on either side is the enhancing walls of the sinus, but the filling defect within it is a thrombus occluding the straight sinus. So this is deep venous thrombosis. The other practical relevance is, of course, to understand the anatomy in relation to tumor surgery. And this area is very, very crucial. It's quite deep. We have looked at the anatomy of this when we studied the epithalamus in relation to the pineal gland and the tectal plate. And you can see the internal cerebral veins, its relation to the splenium, to the pineal gland, and the confluence with the straight sinus. And here we have a patient on the MR scan where you can see the meningioma at the junction, but very important to identify the anatomy so that the surgeon can plan the resection, whether they have to come in above the sinus, above the tentorium, or indeed underneath the tentorium, to realize the anatomy of the internal cerebral vein as it is displaced by the tumor, to realize how the inferior sagittal sinus is stretched above it. And in fact, the internal cerebral vein, instead of draining into the vein of Galen, is draining much more posteriorly into the straits at the level of torcula. So this kind of anatomy is quite crucial whilst planning surgery. Vein of Galen, of course, it won't be complete to discuss that without showing this example of vein of Galen malformation, which is a pediatric abnormality. Typically, it's a vascular malformation at the level of the vein of Galen, which is an AVM, and you can get fistulous components. So this is what we are seeing in this patient over here. Here you can see uh, injection into the vertebral artery with the choroidal vessels, which are then fistulating into this aneurysmal dilatation of vein of Galen, which we are seeing here on the sagittal T2 sequence. This is the normal anatomy, the internal cerebral vein, the vein of Galen, the straight sinus, and here you can see the vein of Galen is dilated because of the fistula. And the other thing to note is that a normal straight sinus is absent in some of these patients, and they get this unusual sinus called as a falcine sinus, which is between the falx cerebri, which is in that direction in the midline, and the straight sinus can be absent, as you can see. So moving on now from the internal cerebral vein, the vein of Galen, the straight sinus, to another deep venous system, the basal vein. Again, a very, very crucial vein for our for the normal hemodynamics, and it's very important to understand its crucial role it plays in draining quite vital parts. And not only that, how it is hemodynamically related to the other venous structures. So as I said, the internal cerebral veins are in the roof of the third ventricle, but the basal veins are somewhere around the base. So, and this is what is shown here on this anatomical picture over here. You can see the brainstem over here. On either side are these basal vein of Rosenthal. So they are not in the midline, they are paramedian, and they are formed anteriorly over here, as you can see, by confluence of veins, and then they swing around along the medial aspect of the temporal lobe, along the in the ambient system. We have studied the ambient system when we looked at the cisternal anatomy, and then going behind the brainstem and joining up with the internal cerebral vein with the vein of Galen, and that's where they will confluence. Of course, we are not seeing the basal vein because this is a midline sagittal MIP image, and this is where the basal veins are located. So let's look at the anatomy in a little bit more detail. So the basal vein is in fact a venous circle of Willis. We've all known of the arterial circle of Willis, but somewhere in history, the venous circle got lost. So let's look at this venous circle of Willis. So like the arterial circle, it is a circle. So for a circle to be complete, it has to be a ring. So the anterior bit here, this is where the basal vein of Rosenthal is formed, and that area here, which is round about here, is the anterior perforated substance. And again, we have looked at this anatomy when we have looked at the sense of olfaction and the MCA perforators, because they perforate this area, and it is formed by two veins, which are the anterior cerebral vein and the deep middle cerebral vein. So the deep middle cerebral is different from the superficial middle cerebral vein, which we have looked at. The deep middle cerebral vein lies within the sylvian fissure, quite often paralleling the MCA. And these two form the first segment of the basal vein of Rosenthal. To complete the circle, the two anterior cerebral veins will join together via the anterior communicating vein. Similarly, on the other side, you have the anterior cerebral and the deep middle cerebral vein. And once this is formed, the basal vein of horizontal gets tributaries by the posterior cerebral vein, and these two posterior cerebral veins will join together via the posterior communicating vein in front of the cerebral peduncle, and that completes the venous circle of Willis: the anterior communicating vein, the anterior cerebral vein, the basal vein of horizontal in its segment 1, the posterior cerebral vein, and the posterior communicating vein. So this is the venous circle of Willis, and it's important to understand this in trying to understand some of the pathophysiology of venous hypertension, as to why sometimes even if the disease is on the right side, you can get venous hypertension in the opposite hemisphere. And again, to show you how the basal vein then via the ambient system is going to join the basal vein via the ambient system is going to join into the internal cerebral vein galenic complex. And this is just to show you that same venous circle of Willis. This is the venous circle of Willis, not the arterial circle of Willis, which kind of mimics this appearance over here. uh, uh, so having formed anteriorly, it's going to course, having formed anteriorly, which is here, is going to course along the medial aspect of the temporal lobe in the ambient system. And this is that ambient system we have looked at before, the same ambient system we have looked at when we talked about the cisternal anatomy. The medial temporal lobe over here, this is this medial temporal lobe with the hippocampus, the temporal horn, and the choroidal fissure. The hippocampus, the temporal horn, and the choroidal fissure, and the ambient system. And in this ambient system will lie the posterior cerebral artery as well as the basal vein of horizontal, quite often seen as two parallel structures, like this case over here. And here as well you can see the two parallel structures, the posterior cerebral artery and the basal vein of horizontal. And here they will drain the choroidal veins, the atrial veins, on their way route, on their way back towards the vein of Galen complex. uh, uh, just sort of going through the anatomy so that we understand it again. The deep middle cerebral vein, the anterior cerebral vein joining to form the first segment over here, and then the second segment is formed where the posterior cerebral vein will join it, and as it swings around over the brainstem. And this is just to show you some variation. You can see how the blood is draining predominantly on the left side, and hence any abnormality, any venous hypertension affecting the right side is also going to reflect in the left side of the brain over here. And just to depict some other bits of the anatomy variations over here, you can see a very dominant basal vein of horizontal, a very small basal vein of horizontal in this patient. Over here you can see normally this would drain into the internal cerebral vein, but what is happening here is a basal vein is then dividing into two and draining into what we know is this is a tentorial edge. You can just about see the cerebellum through the tentorial edge, and this is a sinus along the medial margin of the tentorial edge called as a medial tentorial sinus. So this is just to show you, depict another bit of the anatomy, which is again crucial when we are operating around the tentorial hiatus structures, like for example the previous tentorial hiatus meningioma that we looked at. I've been talking about the segments of the basal vein without spending too much time in details. The segments basically are the first segment, which is formed by the junction of the superficial, by the deep middle cerebral vein and the anterior cerebral vein. And so that's the segment 1 till the posterior cerebral vein joins it. After the posterior cerebral vein has joined it, which is around about here, the segment 2 begins, and round about here in the posterior aspect of the brainstem we get the what we call as a pontomesencephalic vein, which we are not seeing here, but that becomes a segment 2, and the segment 3 is subsequent segment which joins up with the vein of Galen. So here we have segment 1, then the segment 2, and then the segment 3. These are the three segments over here, and this again just to show you that the unusual anatomy. We have looked at this before. This is the superficial middle cerebral vein, which is draining into the basal vein of Rosenthal instead of draining into the cavernous sinus. And this is another example over here. Here you can see how there is hypoplasia on the right side of the basal vein, and a normally or rather well-developed anterior cerebral vein complex on the left side, and hence the blood is being drained from the right side towards the left basal vein of Rosenthal. And just again, I've shown this example of how the basal vein is terminating in on the medial aspect of the tentorial hiatus. So this is the tentorial hiatus here. So this is the medial aspect of it. But not only is it draining into the internal cerebral vein, vein of Galen complex around here, but also into the medial tentorial sinus, which is again shown over here, the medial tentorial sinus. This is actually the lateral tentorial sinus. This is another patient. So another unusual example of venous drainage. And again, the importance to, as I keep on saying, is to understand this anatomy is so that you can forewarn, you can anticipate any of the problems, and also you can understand the pathophysiology of the disease when it occurs. Okay, for the anatomy buffs, I'm going to leave that slide and you can go through that. It's really to understand what the tributaries of the basal vein of Rosenthal are. But as I said, the importance, of course, is to understand the venous drainage prior to any skull-based surgery. It's very, very crucial to understand any AVMs or fistula. So for example, here we have got a meningioma, which is occluding the second portion of the basal vein of Rosenthal. Here we have got an AVM, which is draining via the pontomesencephalic vein into the superior petrosal sinus. And this is a pontomesencephalic vein, which will demarcate the segment 2 from segment 3. So that's the relevance of understanding this anatomy. Okay, so that was about the deep veins. So we have looked at the internal cerebral veins, we have looked at the medullary veins, and we have looked at the uh, basal vein of Rosenthal. So before we go into the venous sinuses, just a brief moment to talk about the infratentorial vein. And these are numerous, and if you look at a venogram, it's very difficult to appreciate what's what, but there is a basic plan to it, and it's a very, very simple plan. And if you understand this plan, the understanding the anatomy is much easier. uh, there are three parallel groups of venous channels. One is the anterior one, so the anterior medullary venous system, which is basically a venous system which runs in the midline, which is in continuity with the brainstem veins. So you have got a cord, which is the anterior medullary veins, which are over here, and then the same venous complex is continuous on the surface of the brainstem, called as the anterior pontomesencephalic vein, and that is continuous as the anterior mesencephalic vein over here. Similarly, you have got the lateral venous system over here, which is called as the lateral pontomesencephalic vein or the lateral mesencephalic vein, and that continues down on the surface of the cord. Finally, posteriorly, more developed in the cord, not so in the brainstem, is the posterior medullary venous plexus. So these are kind of the three venous channels that are there on the surface of the brainstem. And of course, whenever there are three channels, there are going to be communicating veins which communicate them circumferentially or also through the substance of the brain parenchyma. They can have transmedullary or transpontine venous channels, as we can see over here. So these are the brainstem veins, if you like. Similarly, there are a group of veins which are the cerebellar veins. The cerebellum itself drains predominantly towards into two areas. One, it will drain via the anterior cerebral vein, which is towards a structure called as a precentral vein into the straight sinus vein of Galen complex. And then there are the inferior Vermian veins, which drain typically into the posterior aspect of the straight sinus or the transverse sinuses. Uh, the venous anatomy of this usually becomes important only in terms of pathology of venous hypertension. But just to show you what normal veins look like, it's important not to confuse them with the arteries. Arteries are usually a little bit more anterior, that's the basilar artery, and the veins really hug the wall of the surface of the brainstem, if you like. So these are venous structures. This is not going to be the anterior spinal artery. Sometimes it can get confused. So this is a median mesencephalic vein, which is continuing on the surface as the anterior pontomesencephalic vein and the anterior mesencephalic vein over here, you can see. And the other venous structures we talked about were the lateral pontomesencephalic vein, which will drain the petrosal veins. So the petrosal veins are going to drain into the petrosal sinus, which are over here, which drain along the surface of the petrous bone. And we'll look at that anatomy of the petrosal sinuses a bit later on. So this is basically the anatomy, if you like, of the brainstem veins. If you realize where they are located, you can figure out which way they are draining the blood into. So we move on to the dural sinuses next. We have looked at the anatomy of the dura earlier on when we talked about the meninges, and we have realized that the dural sinuses are really located in between the two layers of the dura, the endosteal layer and the meningeal layer. Uh, and these venous plexuses are named according to the location, and we look at where they are located. So you've got the midline over here, but they are also located along the inferior aspect of the falx, and we have looked at the falcine sinus, and we've looked at the inferior sagittal sinus, but they are also located along the tentorium, and we look at some of these tentorial sinuses in a little while. And as you go more laterally, you can see the transverse sinuses, the lateral sinuses, and the sigmoid sinuses. And a special mention later on about the cavernous sinus and its tributaries. So the dural venous sinuses, even though some of our anatomy textbooks show us that they are hollow channels like these, they're quite often trabeculated, they're quite often septated. And it's very important to understand that concept, that it's not just a single tube, but quite often a septated tube. And it's important to realize that, because sometimes that thrombus can occupy only a part of that sinus, whilst the rest of the sinus may be patent. The other importance to understand the septation is because when we get fistulas, the fistula can actually drain into a small septated component of the sinus, whilst the rest of the sinus may be patent. So when you are treating the dural fistula, it's important to make sure that you occlude or treat the component of the sinus which is fistulas, but at the same time you have to make sure that the rest of the sinus remains patent. When we look at the T2 weighted sequence, it's very useful to look at these flow voids in the arteries, but also important to look at the flow voids within the veins. Here you've got the lateral aspect of the transverse sinus over here. You can just about see the flow void along the back of the sphenoid sinus. Now you'll know this is a flow void within the superficial middle cerebral vein. And this is the patient where there is absence of flow void posteriorly. You can see the presence of flow void anteriorly, the presence of flow void within the cortical veins, but the absence of flow void within the superior sagittal sinus, someone with a thrombus also within the transverse sinus, giving rise to venous hypertension. So the sinuses, we have looked at the superior sagittal sinus. The superior sagittal sinus runs along the length of the anterior-posterior of the head, and it doesn't necessarily have to be a single channel, especially anteriorly. It quite often can be multiple, and they can be replaced by parasagittal sinuses. So you can get two sinuses in the front, small sinuses, and the main superior sagittal sinus can be rudimentary, and these parasagittal sinuses can actually drain at variable lengths posteriorly. So it's important to identify the presence or absence of these parasagittal sinuses. And it drains all the way from the foramen cecum all the way down back to the torcular hairophyllae along the internal occipital protuberance. And then you have got the inferior sagittal sinus, which is located along the inferior aspect of the falx, which is somewhere going to be here. And then we have the straight sinus, which will confluence with the superior sagittal sinus along the torcular hairophyllae. And this is again the superior sagittal sinus, show you how it drains on either side at the level of torcula into the two transverse sinuses. And this is a straight sinus, again to show you the anatomy of the straight sinus, how it is located within the falx at the junction with the two tentorial leaflets and separating the supratentorial from the infratentorial compartment. Just a pictorial representation of the same, the superior sagittal sinus draining the vast amounts of cortical veins along the length of it, in balance, hemodynamic balance with the inferior sagittal sinus, posteriorly at the level of torcula, will drain via the transverse sinuses, which also, remember, drain some of the cavernous sinuses and the vein of Labbé, and then the sigmoid sinus, which eventually will drain into the jugular veins. And this is in the axial plane over here. We have looked at the anatomy of the superficial middle cerebral veins as they drain towards the cavernous sinuses themselves, which drain via the petrosal veins along the surface of the petrous bone, superior and inferior, towards the sigmoid transverse junction. And this is the torcula, which is around about here, and the two transverse sinuses as they drain into the sigmoid sinus. The same anatomy on our on CT venogram. We have looked at the straight sinus over here. So that's the torcula, which is formed at the inferior aspect of the superior sagittal sinus. So this is a superior-inferior view. This is the back of the this is a torcula. These are the two transverse sinuses, and you can see the straight sinus, which is joining at the level of torcula, eventually flowing via the sigmoid sinus into the jugular bulb and then into the jugular vein. So this is the traditional sinus anatomy. The cavernous sinus is located on either side of, and we'll look at in detail of the cavernous sinus anatomy later on either side of the sella over there, which will drain blood from the orbit, which drains blood. We have looked at the superficial and middle cerebral veins, and the blood from these sinuses eventually passes posteriorly via the petrosal veins, the superior petrosal sinus and the inferior petrosal sinus, placed along the superior aspect of the petrous bone, along the inferior aspect of the petrous bone, into the sigmoid sinus and eventually into the jugular bulb. So this is how the cavernous sinuses are going to drain posteriorly. They drain, as I said, they drain the orbit and also the superficial middle cerebral vein. Some sinuses which we don't usually talk about but are important to understand the presence of them, because the implications are essential when we are contemplating any treatment. So are the tentorial sinuses. As the name suggests, they are within the tentorial leaflets, and earlier on I showed the medial tentorial sinus, which was located along the medial edge of the tentorium. But much more important, but much more often seen, is the lateral tentorial sinus. We know all the veins which are in the posterior aspect of the temporal bone, along the occipital bone, drain into the transverse sinus. But this drainage doesn't necessarily, so this is a transverse sinus over here, doesn't occur directly. Quite often there is a venous plexus within the tent, and these venous channels drain into this venous channel, and eventually then the lateral tentorial sinus will drain into the transverse sinus. And it's important to identify these sinuses, especially when you're treating fistulas, to understand where exactly is the point of fistulation. Because if you obliterate the transverse sinus and if the fistula is on the lateral tentorial sinus, the fistula is going to remain patent. And it's important to understand the anatomy in relation to pathology. This is again the same example I showed earlier on of the torcula and the transverse sinuses and the lateral tentorial sinuses. Just to share some pathology of affecting the sinuses. Sorry. So you have got a CT scan with hyperdensity that you can see within the vein over here on the CT scan. And you can see the venous hemorrhage as well within that right frontal lobe. And this slide is to show the normal enhancement of the cortical veins on the left side, but relative paucity of enhancement anteriorly. So you can see the thrombus within the superior sagittal sinus anteriorly, and lack of enhancement of the cortical veins anteriorly, but normal enhancement of the superior sagittal sinus posteriorly, and normal enhancement of the cortical veins. So the anterior part of the brain is going to be under venous hypertension, and hence responsible for the venous hemorrhage in this individual. This is again another example of venous sinus thrombosis, to understand the clot within the sinus itself, and the enhancement is the normal enhancement of the dural leaflets. So the dura will enhance normally. As you can see here, this is how the enhancement should be when the blood is flowing through the sinus. There is no blood flowing through the sinus, but this is enhancement on the walls of the sinus itself. And this is to show you what a sagittal MIP image will look like when you see extensive thrombosis of the superior sagittal sinus. And then the blood in this situation is now rerouted through the vein of Trollard, the anastomosis, into the superficial middle cerebral vein and the vein of Labe, as you can see in this patient. If there is thrombosis of the superior sagittal sinus, how the blood is rerouted more along different paths. Another area which is very often we see is with infections around the mastoid air cells. So this is important to identify, to recognize the relationship of the mastoid, the petrous bone, to the sigmoid sinus, which is separated by a very thin bone, the sigmoid plate, and any infection from the mastoid has a potential of causing thrombophlebitis of the superior sagittal sinus, of the sigmoid sinus, and thrombosis of that sinus. This is a patient who's had surgery for a vestibular schwannoma, and you can see the fat graft over here. But then, as a complication, there is a venous thrombosis within the sigmoid sinus at that level. So we saw the cavernous, we saw the transverse sinuses, we have seen the tentorial sinuses. Just let's look at the petrosal sinuses. As the name suggests, these are on the petrosal bone. So there is a superior petrosal sinus, which you can see over here, and it's along the superior ridge of the petrous bone. And then there is the inferior petrosal sinus, which is usually the dominant one, which is along the inferior aspect of the petrous bone. And these two sinuses drain the cavernous sinus and also the retroclavial plexus, the plexus behind the cavernous sinus. And these sinuses are kind of paired structures on either side. And eventually they will drain via the transverse sinus and the sigmoid sinus into the internal jugular vein. I'm showing an example over here of a patient I had treated a long time ago. You can see the coil balls within the cavernous sinus. So the cavernous sinus fistula has been treated. The patient had proptosis. So the treatment was to sacrifice that cavernous sinus. And at that time, you can see there was a small venous channel still persistent, a small amount of opacification, residual fistula still there. And that had resulted in flow of blood into the superior petrosal sinus, which had resulted in brainstem venous hypertension. So you can see the effects of incomplete embolization of the fistula and the venous hypertension in the brainstem at that stage. This is another patient over here. You can see that there is a fistula along the superior ridge of the petrous bone, a superior petrosal sinus fistula, but the patient had presented with trigeminal neuralgia, and you can see how the venous drainage with the venous ectasia is compressing is likely to compress the trigeminal nerve complex as it comes out in this cerebellopontine angle system. So explaining how this patient would have the trigeminal neuralgia. So that was a superior petrosal sinus. So the inferior petrosal sinus is along the inferior aspect, as you can see here, also draining the also draining the cavernous sinus and draining the retroclavial plexus. And this can be a route to approach the cavernous sinus, to treat the cavernous sinus fistulas, but also it is a route to reach the cavernous sinus to drain blood if you're sampling the petrosal sinuses for detecting Cushing's. If you are going to pick up the steroid hormonal changes, if you're suspecting central secretion of the hormone. And this is what the anatomy looks like on the AP view. So this is kind of the nose, these are the orbits, this is the pituitary gland, which drains via the inferior petrosal sinus into the internal jugular veins. And we can sample the blood, so we have to keep catheter on both sides and sample the blood simultaneously along with peripheral sampling to determine which side is secreting, because these tumors are quite often are very small and microadenomas, and on traditional MR imaging you may not be able to decide which side is the secretion coming from, and this can then aid hypophysectomy depending upon which side is the secretory side of the tumor. So this is inferior petrosal sinus. Sorry, I had to mute that because of the phone. I hope you can hear me now. No talk of sinus will be complete without talking about fistulas. I'm not going to dwell too much about the fistulas because I know you will have pathologies of fistulas and AVMs and treatment of them. But this is just to show you how imaging is quite essential in understanding the pathophysiology of disease. So this is an external carotid angiogram. Here you can see the occipital artery. So this is the back of the head, and this is a transmastoid branch. So this is going to be where the petrous bone is. This is a transmastoid branch, which then fistulates on the surface of the lateral sigmoid sinus over here. And this is that same patient with a MR angiogram picture, you can see the transmastoid branch, and this is a site of fistula. But more importantly, then apart from identifying the site of the fistula, is to recognize the venous hypertension, which then changes this fistula into a dangerous fistula, i.e., there is venous hypertension, there is high pressure within this vein of Labe, which is draining the inferior aspect of the temporal lobe, and you can see the venous congestion and what we call as the pseudo phlebitic appearance because of venous congestion, exposing this patient to a very high risk of venous hemorrhage. And this was just to show you how anatomy can be used to understand the hemodynamics of the fistula. Uh, just to show you some variations of the sinuses, like veins, the sinuses themselves can be extremely variable. You can have a very high riding sinus. The split can be very high. You can get sometimes intersinus communication, like for example over here at the back of the torcular, you can see the communication between the two proximal transverse sinuses. And of course, you must know about the dominance of the sinuses. Quite often one of the sinus is quite often dominant, and the other can be small in size and may or may not explain in some patients certainly the symptoms of idiopathic intracranial hypertension. Some unusual sinuses, I've talked about the Falcine sinus in the context of the vein of Galen malformation, but they can be seen in about 2 to 3% of normal individuals. And these are basically unpaired sinuses in the midline communicating the straight sinus vein of Galen complex with the superior sagittal sinus. But if they are dominant, we often see that the straight sinus can be rudimentary. And this is just a 3D angiogram of the same. The other sinus that is seen occasionally, and again, it's important to identify it and mention it because of its surgical implications, is the occipital sinus. And this is a midline sinus over here along the within the posterior fossa, uh, uh, along the posterior aspect of the cerebellum. And if one has to understand if any midline surgery is being contemplated, it's very important to identify this midline occipital sinus. If there is a midline occipital sinus, it typically will drain. So this is now we are at the level of foramen magnum, round about this level. So what happens is this occipital sinus then drains along the margins of the foramen magnum via this venous structure called as a marginal sinus, eventually into the sigmoid sinus or jugular vein. So this is the marginal sinus. Very important to identify these sinuses, especially for surgeries around the foramen magnum, if surgery is being contemplated, because the inadvertent trauma can result in significant blood loss in these situations. To talk about the some other aspects of venous anatomy, I've mentioned the arachnoid granulation earlier on in passing, and basically these are outpouchings into the sinus by which the CSF is being partially drained. We know all the CSF doesn't get drained by this manner, but most of the CSF, the cerebrospinal fluid, will be drained via these arachnoid granulations, which are projections into the sinus, and they can be seen at various levels, either in the superior sagittal sinus. We have seen these filling defects within the vein of Galen, straight sinus complex. But the other typical site, again confused with a clot, is this lateral tentorial sinus, transverse sinus junction. And the clue is to identify the venous channels which are draining towards them. And these are basically arachnoid granulations. Okay, now the final last 15 minutes will be regarding the venous outflows. So we have looked at the superficial venous system, we have looked at the deep venous system, the internal cerebral veins, we have looked at the vein of Galen, we have looked at the basal vein. We have looked at the dural venous sinuses, all the way from superior sagittal sinus, the unusual sinuses, the petrosal sinuses, the tentorial sinuses. But let's see now finally how the brain is going to drain out of the head end. Okay, so the traditional, of course, pathway is via the sigmoid sinus into the jugular vein. But there are other important venous channels for us to understand, and let's look at some of these. So this is the one which is the traditional one. Here you have the superior sagittal sinus, the torcular, the transverse sinuses, the sigmoid sinuses, and the jugular veins. And when we talked about the cranial nerves, I have shown the anatomy of the carotid canal, of the internal jugular vein when we looked at the 9th, 10th, 11th nerve complex. But sometimes the jugular vein bone can be adjacent, and you can see how it can then project into the inferior aspect of the middle ear cavity, and these can sometimes present as fistula, as a tinnitus. And this is again the anatomy we have looked at before. This is the junction of the sigmoid sinus, jugular bulb, eventually entering into the internal jugular vein. And this is a patient with a tumor of that area. This happens to be a glomus tumor over here, which is then occluding the jugular bulb, but also invaginating and extending into the sigmoid sinus. Look at the normal flow void on the opposite side, on the left side, and absence of flow void because of this enhancing tumor which is occluding the venous outflow. So this is the typical outflow track of the cerebral and the cerebellum. But we do have other channels, and these come into play especially when there are occlusions. This will help us understand why venous anatomy is so forgiving, that in spite of multiple occlusive sites, you can still maintain the venous drainage. It will help us identify some of the pathologies that we see. So let's just look at these alternative venous drainage channels. One of them is the emissary vein, which basically communicates between the internal channel dural sinus, like for example over here the sigmoid sinus, and this is an emissary vein which communicates with the scalp vein behind the mastoid. So this is a retromastoid emissary vein. Similarly, you can have small emissary veins within the sphenoid bone, uh, or also within the occipital bone. This is the posterior aspect of the superior sagittal sinus, and you can see the emissary vein which is going to go out and drain via the scalp vein into not the internal but the external jugular system. And this is that same patient over here. The you can see the sigmoid sinus over here, and then the venous channel, the emissary vein, which is going to drain into the scalp venous system. The other outflow is the orbit. So the cavernous sinuses, we know, drains the blood from the orbit into the petrosal sinuses. But sometimes the anatomy allows the blood to actually flow retrograde. And this we can see in patients who have got venous hypertension. So this patient has actually not shown over here is a fistula on the left side. And you can see the superior ophthalmic vein is quite enlarged, allowing for blood to now flow in the opposite direction. And these are the patients who will develop proptosis, ecchymosis, and pulsatile nature of the globe. And eventually from the superior ophthalmic vein, they will drain via the angular vein into the facial veins. So you may see some patients who develop quite prominence of these venous channels on their face. We've looked at on the previous slide. If I were to just go back over here, we have seen this mastoid emissary veins and the midline occipital emissary vein. This will eventually drain into a venous plexus called as a suboccipital venous plexus, which is at the base of the brain, outside around the foramen magnum level, and this is called as a suboccipital cavernous venous plexus, and it is kind of in balance with the internal venous plexus which is surrounding the vertebral artery. So this is the suboccipital venous plexus, eventually that then drains into the external jugular venous system. Okay, I would like to share some moments on the cavernous sinus because it's quite a vital sinus in terms of its drainage pathways, but also quite vital in terms of understanding the pathophysiology, but also to look at the surgical implications and the medical implications. So let's look at the anatomy of this. Okay, so we have looked at the cavernous sinus anatomy when we talked about the sella and the paracellar region in detail, and we have understood how it's again like other venous sinuses. It is trabeculated. It is located on either side of the pituitary fossa, and its contents, which include the cranial nerves, but also the internal carotid artery. In terms of the venous anatomy of the cavernous sinus and its drainages, we know now that it will drain the superficial middle cerebral vein. So it drains a lot of brain itself. It does drain the orbital veins, the superior and inferior ophthalmic veins. So here it's kind of a pictorial depiction of the same. So the orbit and the orbital veins which are draining back via the ophthalmic superior and inferior ophthalmic veins into the cavernous sinus, and hence any fistulas in relation to the cavernous sinus are going to result in venous venous hypertension of these ophthalmic veins, resulting in proptosis and ecchymosis and pulsatile nature of the disease. And this is just sort of a pictorial representation of the venous drainage and the tributaries of the cavernous sinuses. So these are the two cavernous sinuses on either side. And then we have the superficial middle cerebral vein, which sometimes will form a sphenoparietal sinus that drains into it. We know the ophthalmic veins which drain into the cavernous sinus. And then we have already looked at the superior and the inferior petrosal sinus and the retroclavial or the basilar plexus, which can drain which drains the cavernous sinus eventually into the lateral or the sigmoid sinus, or earlier on, as I showed, the marginal sinus, which is a continuation of the occipital sinus. So this is kind of the anatomy of the cavernous sinus itself as to what it drains and where it drains into. But the direction of flow will be really dependent on the hemodynamics of that area, will be dependent on if there is any pathology, if there is any obstruction. Also important to realize that the two cavernous sinuses talk with each other via the intercavernous plexus, and sometimes you can have pathologies presenting on the right side, whilst in fact the disease is on the other side. So again, to look at the cavernous sinus anatomy, on either side of the sphenoid sinus of the sella, you have seen the cavernous carotid artery, and these are the cavernous sinuses which are enhancing. We have seen the superficial middle cerebral vein which drains into the cavernous sinus, and then the drainage of the cavernous sinus via the superior petrosal sinus and the inferior petrosal sinus. This is the patient with cavernous sinus syndrome, and you can see not all pathologies are surgical. You have got a patient who's got cavernous sinus thrombosis. You can see the filling defect of an enlarged sinus. A normal sinus is never as enlarged as this one, and you can see the big filling defect. The big filling defect as a result of infection within the sphenoid sinus that has resulted in cavernous sinus thrombosis. Again, a medical emergency. This is the patient with a fistula of the cavernous sinus. This is a keratico-cavernous fistula, and here you can see the enlarged superior ophthalmic vein, which we have been talking about, which would explain why this patient would have the symptoms typical symptoms of a keratico-cavernous fistula. Let's look at some angiographic anatomy of this keratico-cavernous fistula. This is a right internal carotid angiogram, and this is to show you how the disease actually is on the left side. And you can see these are the branches from the right internal carotid artery which go across the sella and are highlighting the venous plexus surrounding the carotid artery. So this central hole is actually the internal carotid artery that we are seeing, which is highlighted. So this is the same internal carotid artery on the opposite side over here, which is being highlighted, but the artery doesn't opacify because the injection is on the right side, and the contrast is actually surrounding the carotid artery. And then the fistula. And this is that same fistula on the left side. You can see the internal carotid artery over here, which is supplying the fistula, multiple small branches, and then the cavernous sinus, which is opacifying quite earlier on, and then the superior ophthalmic vein, which is opacifying much earlier on, much before any of the cortical veins have opacified. Just a magnified image of the same. So this is we have looked at the anatomy of the cavernous carotid artery over here, the dorsal branches of the inferolateral trunk, the meningohypophyseal trunk, and then the small tributaries which will opacify the cavernous sinus, and then the superior ophthalmic vein. And it's important to evaluate this anatomy, because then you can understand the pathophysiology of why this patient has a high risk of hemorrhage. You can see that this is a cavernous sinus over here with its and the reflux into the cortical veins, the reflux into the inferior and the superior petrosal sinuses over here, and the reflux into the ophthalmic veins. So this patient is not only at a risk of losing the vision because of the ophthalmic complications, but is also at a risk of having a venous hypertension and a brain hemorrhage as a result of that. And then you can plan treatment. So this is a patient who's been then treated with sacrifice of the cavernous sinus via a transorbital route with a catheter and coils inserted from the ophthalmic vein. just the last few minutes now, some initial bits of anatomy to talk about sinus pericrani. These are basically anomalous communication between the intra and the extracranial venous system, and they basically drain through a calvarial defect, which is not normally present in individuals. They're typically in the midline, quite often seen in the frontal region, and the patient will complain of a swelling that develops, especially during Valsalva when they're bending or straining. And it's important to realize that they drain a normal venous channel. So if you see someone who's got a swelling, which may or may not be pulsatile, which comes up during Valsalva, it's important to look at the venous anatomy carefully before operating. Otherwise, the patient is going to get venous ischemia of the brain that's being drained. And just finally, to talk about what is a developmental venous anomaly. Unfortunately, the name anomaly has stuck, but it's not an anomaly. It's how the veins have developed in that part of the brain, and it represents a single channel which drains multiple tributaries, either superficially or deep, typically located along the margins of the ventricles or within the cerebellum around the fourth ventricles. Again, important to realize that they drain a normal brain. Occasionally, they can be associated with vascular malformations, typically a venous angioma, or can be a cause of venous hypertension. And this is what they look like. So here you have a developmental venous anomaly along the margins of the frontal horn. This is a frontal horn, and you can see how multiple small tributaries are draining via a very prominent channel towards the via a single vein towards the superior sagittal sinus. Occasionally, it can be difficult to exclude a AVM, and you may need to resort to catheter angiography. But this is another typical example over here: multiple small tributaries draining towards the ventricular margin in this posterior fossa developmental venous anomaly. A coronal reconstructions, you can see another developmental venous anomaly draining cerebellum inferiorly. And you can see them better on an MR scan. This is an axial T2, and you can see the low signal within that developmental venous anomaly main trunk. And this is a SWI sequence, just to show you how multiple tributaries will join up together to form a common channel of the capet-like appearance, if you like, and seen again on this post-contrast scan to show the typical appearance of a developmental venous anomaly. And sometimes they can cause pathology, especially if they get thrombosed. Like in this example over here, you can see the developmental venous anomaly, and some of the tributaries were thrombosed, giving rise to venous hypertension. They can develop stenosis as well, and that can cause venous hypertension within them and can cause calcification as well. So this is what a developmental venous anomaly looks like. I think probably that probably is my last slide. Yes, that is my last slide. So that I just wanted a brief moment here to pause and remember and think about the venous structures, the anatomy, and the immense contribution they have in draining impure blood, because it's so vital to understand that bringing pure blood is essential, but also draining that impure blood away from the brain is equally vital. I think I'll stop there, and I'm more than happy to take any questions. Thank you. Are there any questions to ask?
Hello, can I ask you a question?
Yes, yeah. Can you speak out, please? I can't hear you very well, but just about, yeah.
Hello, can you hear me now?
Yes, I can, yes.
I have a question regarding your previous lecture. Is it all right? Concerning the arterial anatomy?
Sure, please, yeah.
You mentioned about the origin of the anterior spinal artery coming out from the vertebral artery.
Yes.
I have a question. Is it safe to put a stent? Is there a risk if you have like a vertebral artery dissection and you would like to put a stent into it? Is there a high risk of causing the spinal cord ischemia by putting the stent in?
So it depends on the type of the stent that is being used. So the traditional stents that were used, which were to support the coils, which were metallic stents, non-braided stents, will have enough pores within them to allow flow of blood into the anterior spinal artery. The risk is slightly higher if you are using more of the braided stent, especially the pipeline. But the philosophy of the newer stents, the pipeline or Leo or whichever ones you choose, is that if the artery demand is necessary, then the artery should stay patent. But I think I have to say that there is always a risk when you're crossing an artery, especially with a braided stent, like a pipeline or any of the newer ones. There is a small risk of arterial occlusion. I have certainly had complications, not with the anterior spinal artery, but around the superior cerebral artery perforator being blocked off following deployment of the stent. So you always run that risk of thrombosis, especially in small arteries like the anterior spinal artery.
Thank you very much.
Okay. Any other questions? Okay.
Yep, there's one question from Saba, one of the neurosurgery registrars.
Yep.
She's asking if you consider a good quality CTV sensitive enough to pick up cortical venous thrombosis.
The question is very important here. We are talking of cortical venous thrombosis. So I think it's different than a venous sinus thrombosis. So I'm a great proponent of CT venogram for venous sinus thrombosis, but if you're suspecting cortical vein as opposed to a sinus, then I would certainly suggest an MR scan, because MR with the SWI sequence and a post-contrast scan is very, very sensitive to pick up isolated venous thrombosis. And we have certainly seen recently cases of cortical vein involvement as either with radiotherapy or because of infection. Certainly see them in the pediatric age group as well. So if you're suspecting cortical vein thrombosis, I would suggest that we could consider a MR scan with the appropriate sequences. But for all practical purposes, otherwise, which I'm a big fan of CT venogram.
That's great, Dr. Herwadkar. Thank you again.
Okay. Thank you, team. Have a nice Sunday.